Good afternoon, ladies and gentlemen. I think Dr. Sinha and Dr. Joshi have taken you into the fast track. They've negotiated all the lanes and they've gone up all the ladders, as they said about step ladder pattern. My job today is to see how we can make the Indian diabetic live well and live longer. You already have a keen insight into pathophysiology, the various hormonal issues, the various options available. And I think Dr. Joshi has quite nicely narrowed it down as to the devil we know being better than the devil we don't. We all know that Indians are different in all facets. And the Indian response to gliptins is not 0.5 to 0.9 as the textbooks from the West say. All our studies have shown that the Indian response to gliptin is probably even more than 1. So they definitely form into intermediate, but maybe into better options. Have we thus optimized the role of treatment of patients with type 2 diabetes? And where can I use a DPP-4 inhibitor? Now, what do the guidelines say? I'll take you to the guidelines of 2009. And in the 2009 guideline, as you will say, which was not officially endorsed by either organization, the ADA or the EASD, there was no mention of the DPP-4. There was, of course, mention of the GLP-1 receptor agonist. But then we moved quickly to the 2012 ADA algorithm. And I think, Dr. Joshi, this definitely showed it to you. And there you are, along with everything the DPP-4s featured. This slide, what Dr. Joshi showed, I want to show again, because the DPP-4, the side effect which I have highlighted, the side effect profile is rare. We really haven't seen significant side effects with the DPP-4. So the ACE 2013 glycemic control algorithm also talks about DPP-4. But we don't want to talk about algorithms because we in India are bedside clinicians. The difference between all of you and us as against the West is that we treat the patient at the bedside. The Westerners are more in the armchair and more in the guidelines. So you will make the decision what to use. So your point of view is probably more important because you know your patient best. You know your eating habits. And I'm so happy to have come to Chennai because I'll get rice and idlis in the morning, I'll get rice curd in the afternoon, and I'll get all my dosas, which I don't get in Bombay. So we have to tailor it according to our requirements. And if you look at the profiles of anti-diabetic, look at the different medications. I want to show you the DPP-4 only. Neutral for hypo, neutral for weight. Renal dose adjustment may be necessary and can be done. Hardly any side effects except for those rare esoteric pancreatic problems. CHF and cardiovascular safety, neutral as of now. And of course, bone, it is neutral. The reds are spread all over. And I'm not going to talk about AGIs and colselvalan. It's the others which show a lot of red. There is no red with the gliptins. So what is the efficacy and safety of gliptins in patients with type 2 diabetes? I think this has been clearly shown to you that the DPP-4 inhibitors increase insulin in a glucose-dependent fashion, reduce glucagon. Remember, glucagon is not the poor cousin of insulin anymore. It is the twin brother and is allowed and will gain as much inheritance in the treatment of diabetes as insulin. All this leading to improved physiological glucose control. What does a single dose of sitagliptin do? A twofold increase of active GLP-1 and GIP, a 22% increase in insulin, a 12% reduction in glucagon, and a 26% reduction in plasma glucose. Now this slide is very important because it shows me all the pathophysiologic defects that Dr. Sinha addressed. All of them have been significantly addressed by a single dose of sitagliptin. So, sitagliptin is the apple with the extra thrown in, because everything that you wanted in the pathology and pathophysiology is addressed. Let's look at the efficacy data of sitagliptin. At monotherapy, after metformin, after SU and metformin, after the glitazones, after insulin, everywhere the studies show sustained, durable efficacy. So they offer reasonably good efficacy when used across the spectrum of diabetes. And the pooled safety analysis of about 15,000 patients clearly show how sitagliptin has had hardly any problems. So therefore, they offer a placebo-like safety. And the sitagliptin also improves markers. Now this is probably something that has not been alluded to. It reduces the pro-insulin to insulin ratio. It improves HOMA beta. Now these are markers taken in a study of 24-week monotherapy. And if you can see these beta cell markers, where they clearly showed it increases insulin secretory capacity, it reduces insulin resistance, and what does it do to the beta cell stress and the immature insulin? It reduces it. As in the West, when I was attending a meeting some time ago, they all said, lose your middle and preserve your beta cells. And that's the motto which we want to adopt when we treat. Having said that, look at the detrimental effects to the beta cells which gliptins do not have. In fact, they are beta cell friendly. And how about using gliptins in the comorbidities? You see, today, comorbidities has become a very big thing. Because once you have diabetes, the chase begins. Immediately, is it affecting the liver? Is it affecting the heart? And the Western world, especially America, has that 3-year cardiovascular safety. I wonder that if metformin was to be discovered recently, whether it would also go through this 3-year cardiovascular safety and pass with the flying colors. Who knows? Now we know that diabetes increases the risk of chronic NAFLD, and that we can see of diabetes with no diabetes. And the prevalence of NAFLD, non-alcoholic fatty liver disease, in patients with diabetes is enormous. No diabetes, normal patients, you have hardly nothing. Fatty changes, 38% of 5 years diabetes, 84% 5 to 15, and 92%. You know, the most difficult question that I, as a metabolic physician, have to answer is when they come with their total medical checkup. 32-year-old executives, 45-year-old middle-aged people, and 55-year, all of them have fatty liver. And they all say, where does this fatty liver come from? And unfortunately, you know, like hypertension means more stress, fatty liver means fatty food. It is difficult to explain to them that the Indian gene is primed to NAFLD. And it's this prevalence in type 2 diabetes mellitus which increases further. So, the gliptins in hepatic impairment, unfortunately, vildagliptin cannot be used. Sita, there is no dosage adjustment required at all. Saxa, again no dosage adjustment, and linagliptin, again no adjustment. So the summary of mechanism of action, how does this work? Whether you go the incretin pathway, there is a prolonged GLP-1 receptor activation, there is weight reduction, improvement of hepatic insulin sensitivity, improvement of fatty acid oxidation, and inhibition of fibroblast growth factor 21, so no fibrosis, no cirrhosis, and the net result, non-alcoholic steatohepatitis and NAFLD improves. So if you look at the summary of sitagliptin in hepatic improvement, whether it's diabetes complicated by NAFLD, diabetes complicated with hepatitis, treating plain NAFLD, or the effect on insulin resistance and steatosis, All this is well controlled, and studies have shown that sitagliptin helps in controlling the NAFLD. Probably for the liver, sitagliptin acts as a cleanup. And that's what you're interested, because the fatty liver, every year the joker comes to you, sir, my fatty liver is not improving. And you have nothing in your ammunition to fire. So, let's look at the second thing, gliptins and cardiovascular disease, living on the edge. All drugs are very scared that they may not reach the safety. Now we know the summary of incretin actions on different target tissues. And if you look at the selected mechanistic trials indicating a CV risk modulation potential of the DPP-4 class, they decrease myocardial infarct size, increase endothelial function, reduce inflammation and oxidative stress, reduce the atherosclerotic plaque, improve left ventricular function, decrease triglycerides, and also a favorable action on blood pressure. So it looks nice for the heart. The cardiovascular safety therefore shows that DPP-4 inhibitors have a reasonable history of cardiovascular safety. As Dr. Joshi mentioned, Thacker and Boston in ADA, Savertimi, Carmelina are all these studies which will come up and will show us that overall there is a lower risk of CV events. We will have to wait and watch, but at least it seems that there is, the pooled data shows that there is CV safety, and no statistical significance was found in any of the currently available studies for major cardiovascular events. And of course, the Savertimi, the Examine, which are the completed ones for allogliptin and saxagliptin, they clearly showed a non-inferiority hypothesis for MACE. Yet, we are waiting for the remaining, and we'll get a clear picture as to whether amongst the entire ammunition there is a red mark to show, but it doesn't look like. Now, what about sitagliptin in patients hospitalized with ACS? As physicians, we see acute coronary syndrome, and the patient really, when he gets in, he has newly detected IGT, impaired glucose tolerance. And in these patients, you need to give this beta cell disturbance a drug like sitagliptin, and it seemed to be very, very good. CKD, the other bear bug of diabetes. You know that 43% of CKD in this country and probably the world over is because of diabetes. So the diabetic individual with CKD needs special attention and individualized management of hyperglycemia. If you look at the etiology also, diabetes is definitely high on the cards. Now look at the dosage adjustments for the different diabetic medications. The DPPI, you can adjust the doses. The others, either you cannot give or you can give, but the focus is very small. So let's focus it to the DPPI, DPP-4 inhibitors. The OHAs and renal guidelines from the Canadians have clearly showed that there are fewer treatment options as far as OHAs are concerned. Metformin cannot be given. Linagliptin can be used. Saxa, they are not very sure, but Sita is the only gliptin which can be used safely in the different stages, but of course with dosage modulation. So all DPP-4 in general are safe in various degrees of renal impairment, especially the Sita, Vilda, Saxa. You have to use an effective dose in renal impairment, which is lower than the usual dose. Linagliptin, from that point of view, is excused from the renal angle. The efficacy, this slide was shown by Dr. Joshi, which shows even in moderate to severe renal impairment, Sita did its job better than the shorter SUs. So if you look at sitagliptin, you can go down from 100 to 50 to 25 milligrams in end-stage renal disease where dialysis is going on. And it's a bold gamble when they took the study where they gave 100 to the U creatinine, they gave 50 for mildly impaired GFR, and they gave 25, as you will see here, and you found equally good efficacy and tolerability across the board. So sitagliptin, now this is a new study because renal transplant has come of age. So new onset diabetes after transplant is no doubt. And we have seen that the diabetic who now convinces one of his relatives, I'm not going to talk about what happens south of us, but who convinces one of his relatives to get a kidney, the poor chap still seems to be having impaired glucose tolerance with the new kidney. Or he develops new onset diabetes. In these patients, they have done a study with sitagliptin, and we have seen the additional benefit of sitagliptin because there is a special emphasis on weight gain, and importantly, sitagliptin does not interfere with the immunosuppression medication. So this is important. They compared it as class molecule, a truly once daily with a 90% and more trough of DPP-4 inhibition, can be taken any time of the day, independent of the meal, can be used as monotherapy and married to any other OHA or injectable. It has the longest 4-year monotherapy study. 100 milligrams once a day can be modified in renal conditions. Efficacy is assessed in mild to moderate hepatic impairment also. Short-term studies indicate that CV benefits, there is no ill effect. We'll need to see that. What is the conclusion? That DPP inhibitors are a novel class of agents. In India, we have the test of time. 5 years ago when I was here giving a talk, DPP-4 inhibitors were new, but now it's something that we know. Patients want therapies that are effective, easy, safe, tolerable, affordable. The drug that achieves the most favorable balance of these characteristics will have the highest appeal. It improves the patient health outcomes, possesses strong efficacy, and provides robust glucose control as well as non-glycemic benefits, and is seen to be safe. So have we truly optimized the role of DPP-4 inhibition in the treatment of patients with diabetes, type 2 diabetes? This is the wish list for 2015. We are in April. I look at the beginning of the year from the financial year because all that we doctors do is write prescriptions and pay taxes. So 1st April is our new year. You probably have to pick the genius in your armamentarium. And since you are Indian, you will have to take the lead as Gandhi did and work only for your patient. Thank you for your attention.